Oh,
Hello, everybody. Welcome to Office Hours. I am your host, Coach Joshua. So good to be with everybody. All right, we've got some familiar faces. Hey, Becca, how you doing?
oh,
Hey, so how's it going? Let's start with you, Becca. Glad to see you, by the way. How are you doing? I'm
It
just
is good to
pulling up.
see you too. I'm doing good. You'll hear my kids in the background. They're swimming.
Okay, all right, no problem. So how's everything going? I'm just pulling up the iPad.
Everything's going good.
Okay. And do you have your exam scheduled already?
Yes, it's on August 14th, I believe.
Nice. Okay, so that's a little over a week away. And what
hmm
attempt number is this for you?
Now, this is number 6, so this
Okay,
is
no
my
problem.
final
All right,
one.
so no problem. Have you seen the new class marker exams?
No, I have not.
Okay, here, well, let's talk about that really quickly. This will benefit everybody, but especially you, because I want you to take action on this right away. So
Okay.
let me get that up on my screen. We ended up with a fly in here. Okay, so all right, so here's your general dashboard in school. You're going to go to the 14 days program,
hmm
go to class marker exams.
Oh, okay.
And then what I want you to do is you should just check your email, do a search in your email inbox, search for class
hmm
marker. You should have received an email probably, I don't know, maybe 2 or 3 weeks ago with
Okay.
your login information. If you don't know that
hmm
or if you can't find it, then just let me know. We'll get your password reset for you. But
Okay.
inside of class marker, so when you go there, hang on 1 minute. Let me get logged in. Sorry about that. I didn't have it pulled up. So, um, let's go to paramedics. Okay, let's go to exam assigned. All right, so when you get there, you're going to see there are 5 diagnostic exams. There are also 2 final exams. There's final exam 1B and final exam 2. And there's several
Okay.
subject or topic specific exams. So there's one on shock.
Awesome.
There's one on cardiology, resus and EKGs, endocrine, Vaughan Williams classifications, as well as acid base disorders. And the reason those
Okay.
specifically are there are those are the ones that people have the most trouble with. Okay.
Okay.
So I want you to start. So it's probably 10 or it's actually 13 exams at the paramedic level. So you can literally start doing like 1 or 2 a day today. Where are you on the cohorts in terms of cohort 1, 2, 3 of the 21-day game plan?
I am halfway through cohort 2.
Okay.
I think, or pretty close to wrapping it up. And then I should be starting on cohort 3 at the beginning of next week.
Okay, that'll be good. Yeah, that would be great actually if you could finish cohort 3 next week. Now, I want you to know it's not 100% necessary that you complete everything. It's just if you
hmm
complete everything, that gives you more, chances for success. But on every
Right.
cohort, on cohort 1, like there was a time when it was just cohort 1, there was no cohort 2 or 3, and we still had people pass just with that alone.
Right.
In fact, there were no class marker exams, there was no rapid drills, none of that. It was just the videos, and people still
Right.
passed with just that. The other thing that you may want to look at, especially if it's been some time since you've been out of school, um, you may want to look at doing the private sessions with us. You don't have to. I just sent somebody a message today that in the last 2 months, we've had 8 people pass on their 6th attempt in the last two
hmm
months. So
Okay.
the majority of them did not do our private coaching. They only used the information in the cohorts. However, if you feel that that would be beneficial, by all means, take advantage of that, and we can
Absolutely.
get that scheduled. Okay, so you can just reach out to me privately about that. Any questions
Okay.
about anything?
No, no, it's all doing phenomenally well. Very repetitive, so it's really starting to stick. And
Okay,
I still sit down and draw out my little piece of paper with all your drawings, copying them all with
nice,
the oxygenation, the ventilation, perfusion,
nice.
LAD, just all the things. I draw it all out on a whole sheet of paper. It fills it all up. So that way, when I sit down and I have my little piece of paper that's there for National Registry, I can copy all this stuff down. So it's just a quick
Okay, good.
reference
And
guide
just
for me.
in
And those
fact,
are the things that go with.
this is for
So,
everybody. So I want to share this. In fact, let's start off with some wins tonight because I've been so excited all day. I couldn't wait to get to this session. You may have seen if you've been active in the school community over the last 48 hours, I've now made, I think, 7 posts total in the last 48 hours of people who've passed. Just in the last, well, yeah, just in the last 24 hours, um, we've had, I think, 4 or 5 new paramedics, but 3 of them were all women who passed on their first attempt. We had Monica, then Marcia, and then just moments ago, I just announced Leona passed. Leona just graduated a week ago from paramedic school, but she was already in the program. She actually took advantage of the program while she was still in paramedic school, which is great. And 1 week later, just knocked out her exam. Just got the results today. So uh, we had a new advanced CMT, Mason. Mason was actually somebody who came through during our NRMT past study course when he was an EMT student. He had some trouble initially. He came to me. We did private coaching. He went and passed his EMT exam. I recommended that he start with me for his advanced CMT. He said, Coach, I got it. I said, okay, no problem. He went, he failed his exam. But then he was like, you know what, Coach, I probably should take you up on your offer. He came back, did private coaching, and just knocked out his advanced exam yesterday or the day yesterday, maybe yesterday or the day before. He just knocked out his exam. So there, literally, guys, there have been like 7 new people who passed their tests in just about the last in the last week, and uh, 5 in the last 48 hours. So that's something we're really excited about. Now, I want to hear from you all. Tell me some of your wins this week. So what I want you to do is come off mute for me. I'll call on you, and then here, actually, let's do this. Just raise your hand, and we'll call on you in order. Hit the reactions button at the bottom of your Zoom panel, and then I'll just call them in the order they pop up on my screen, just so that we're not all talking at once, and I can pull you up so that I can see you. Okay, not the thumbs up, but but the hand raise button. Okay, here, let's just start with you, Christian. So, since I happen to see you, let's pull you up first. Let's start off with what are your wins this week? So that can be that you learned something that you didn't know before. It could be that you were able to take what you learned and translate it to patient care. You had some aha or some bulb moment. What's your win so far this week? Or for over the last week?
Hmm. Well, I mean, my biggest win over the week, just because I'm just kind of starting with you,
Okay.
was the whole breakdown of how to approach the questions on the
Mm.
test.
Mhm.
The 5-step method is
Mhm.
is huge, and is going to save a lot of time and all that on the test. And that 5-step method, and then the star method as well, and then our seed, all of
Okay.
those put together on how to break down the question and get to the answer you need in the timeliest manner has been the biggest
Oh,
aha
I'm
moment.
so glad you said that. Hold that thought for just a second. Let me pull up a message. I just got this today, just like an hour ago. It was Cody, 58 minutes ago. I just got this. So Cody said, because I asked him to come on and share this himself tonight, but he said he's with family. He said, I'm going to be with family at the time. I'd love to, but unfortunately, I can't. If you can tell them anything, the 5 steps to answer a question, oxygenation, ventilation, and perfusion, the seed tricks, the 5-star medic method. This is awesome. I'm starting to enjoy learning again after being out of it for a while now. And the crazy part is, I'm just getting started. Please tell them to follow your steps and pictures that you share and teach us. Cannot emphasize that enough. Thank you again and always. Crazy to see all these people getting their certifications from yesterday back to back. That's great to see.
Mm,
So exactly what you're saying, the 5-star medic method, the seed tricks, the oxygenation, ventilation, perfusion. I mean, this is my framework.
mm,
That's the whole framework, right? And it really does work. So glad to hear that it's working for you. One of the things I'll say, Christian, is you guys hear me say things like, hey, I don't want you to be a 950 medic. But I promise you that's actually what's happening. Like, I don't want you to be a 950 medic. I really want you to be great when you go out there. And other people will start to notice. They'll say, how do you know some of this stuff? Monica just said this yesterday. She's like, people other paramedics, senior paramedics. She was telling me about a guy who's been a paramedic with at her service or whatever for years, for decades. And he was asking her, like, how do you know stuff that I don't know as a 20 plus year, meaning him, as a 20 plus year paramedic? And it comes down to how we're teaching you to think. So I think you're going to, I'm confident that you will figure out that your knowledge will go to a much higher level. Just stay engaged with us, keep showing up like you're doing, and I'm looking forward to helping you win. Okay.
Thank you.
Yeah, no problem. Let's go to Logan. Logan, what's your win for this week?
I mean, I would say my biggest win was the first live training that I did, because it really opened my eyes to what we can accomplish. I mean, what can be accomplished through going through your program. I mean, I've taken stuff from that first thing that I never thought I would ever know. And
Such as what? Be more specific for me.
well, I mean, I can go with a little one. I mean, I never knew about how Narcan binds to the mu receptor, and now
Okay.
that's like stuck in my brain. I could go tell somebody that tomorrow. It's like I didn't even have
Nice.
to go back in my notes and look at that. So it's like just stuff
Nice.
like that. Anything, that I wouldn't really think that I would need to know, but now that I do know, I can go tell that to somebody without even having to go back in my notes. I could just spit that back out.
Right. And how does that make you feel to be able to kind of share information that way so easily?
I mean, it makes me feel a lot more confident about going and taking the test again, that's for sure, because like it kind of impresses me that I don't have to actually like dump that information onto a piece of paper. It just kind of stuck with me. It's like
Mm.
just little
Mhm.
things like that. I mean, and there's other things too. That I kind of picked up through that session that kind of stuck with me as well. That will really help to make me feel more confident going into that exam. It's less stuff really that I have to dump onto that piece of paper when I go in there, and stuff that I can just pull out of my head,
Mhm.
which is nice.
And the thing about when you have the information just kind of organized like that is you
Mhm.
don't have to worry about memorizing so much because you can just kind of see patterns. Like the biggest pattern that I'm teaching you all is everything comes down to oxygenation, ventilation, perfusion, right? So anytime you have any kind of patient situation, this is on a test, this is in real life. Any call you go on where if you can get it down to, hey, well, what's the actual problem here? Like no matter what you call it, like no matter what the diagnosis or the name of it is, if I can get it down to, well, it's an oxygenation problem, it's a ventilation problem, it's a perfusion problem, now I know how to fix it, right? I don't even know what it's called, but I know what to do about it, which is really important when somebody's life is on the line. And you're able to come up with those decisions in split seconds without being stressed out. Because I can now immediately figure out, okay, this is what I need to do. This is the problem. Let me tackle that. Once I figured out that problem, now I can then say, okay, well, what's the next thing that would kill them in the next 5 minutes if I don't address that? And I just keep asking that. What's the safest thing I can do right now that fixes the current problem? Once I take care of that, did it work or not? Okay, I seem to be improving. Now, what's the next thing that would kill the patient? And I'm just going to keep asking that same question over and over and over. Does that make sense?
Yep.
Okay, cool. All right, let's go to Thomas. I saw you next in the list. So, Thomas, give me a win for this week.
I'd say 2 wins for me this week. One is finally getting on live for the first time yesterday, which is a really good experience.
Nice.
And then
It feels a little
another
different, right? When we're
yes,
live together
it's a lot
versus
better.
just watching me.
Yes,
Yeah.
it definitely is different.
Okay.
And then I'm trying to work more on like the why behind things with the pathophysiology. So I watched the video the other day, the one you posted about the cellular mechanics at ST elevation.
Yeah.
And
Right.
about ischemia, making the sodium potassium ATP pump kind of not be able to function. Sodium gets trapped inside, then chloride falls. That makes salt pulls in the water and kind of expands, ruptures, and then what's you call
Do
it,
you
leaks out
guys hear this?
troponin. So that was pretty cool to know because
Nice.
I know what a STEMI is and how to spot
Now,
it
hold on.
and
I
how
got to
to treat
interrupt
it.
for just a moment. That was good, man.
Yes,
You're
sir.
cooking. So let me ask you, when you just rattled off all of that stuff, was it
Mhm.
because you just had a picture in your head?
I would say yes.
Okay.
I kind of picture in my head and there's like how it flows. So just kind of like the way you describe things, it's easier to learn and absorb.
And how was that different than how your paramedic instruction was in school or other programs that you use, or well, you just finished school, so I don't know that you've used other programs.
Correct. I've watched other like YouTube videos and other
Mhm.
channels, but I never really followed an official program
Mhm.
other
And so
than
what's
just
the
med school.
difference that you've noticed yourself?
More of a big picture thinking, seeing like the
Mhm.
total big picture and how the body works all together, not just individual parts or units
Mhm.
or, you know, systems.
It will also help you when you go out there and let's say you're with your fire department, you have other seasoned fire medics who work with you who don't know
Mm,
half of what you know because they just know what they've memorized. They know the same stuff that everybody else knows, that every 950 medic knows, right? But they don't
correct.
know it all how it all connects. Like they know dots
Mm,
of information, but nobody's ever drawn the picture to connect the dots. You knowing that, it's going to translate to you being able to give much better patient care, and you'll be a lot more calm under pressure because you're not so stressed out trying to figure out, well, what's wrong. You'll be able to immediately figure out what's wrong, and then now you can immediately get to action, but you don't have to be stressed out. You can just say, hey, all right, this is a problem, this is what we do for that problem, let's do that. Okay. and
mm,
and that's one, and in fact, I don't want you to wait until after you've passed the test. I want you to immediately start putting this knowledge to use right away. On your very next call, filter it through, is it oxygenation, ventilation, or perfusion? And just use the stuff that we've talked about. Like go back and review that ACLS PALS review. That's a great one. Becca, that would be a great one for you to go back and see as well. The ACLS
mm.
PALS review under the replays. So in the 14 days program, you have here, let's just pull it up on the screen. In the 14 days program, you have cohorts. You have cohort 1, cohort 2, cohort 3, final week before exam, and then this office hours live session. So we've done a lot of live sessions lately. There's this acid-based one. That's a great one for a lot of people. This ACLS PALS review would be like probably one of the top videos I would encourage you to go back and watch because it's the bread and butter of EMS. It's going to
Mm.
help you in a lot of situations because it's like your everyday job. And the Med Math Made Easy is a great one to rewatch for drug calculations, like how to do every type of drug calculation you'll ever have to do in your career. All right. So, anything else you wanted to say, Thomas?
Well, with the oxygenation, ventilation, perfusion triangle, I did have a seizure earlier today, and the first thing I knew was like this guy's he's gonna need oxygen. He was breathing pretty fast, but I knew he'd be, you know, hypoxic more than anything. So he
Mm,
was post-ictal in his vehicle when we got to him. But as
okay.
you know, simple. First thing I did is put a non-breather on him, and then we had to. He wasn't the driver, mind you. It was his mother, and you know, he just forgot to take his meds today. But that was the first thing we did. You know,
Now,
of
let me
course,
ask
he's
you a question.
post-ictal.
All right. So,
Mm,
let's say this patient is post-stictal. So, that by itself means altered mental status, right?
mm-hmm.
Okay. Is that patient stable or unstable if they have altered mental status?
Oh, unstable.
They're unstable.
Definitely
Okay.
unstable.
So all of our fixes come down to oxygenation, ventilation, or perfusion. We have a seizure patient. This patient was spontaneously breathing on their own, right?
Mm-hmm.
Okay. Because you went with a non rebreather. What would have been probably a great thing to do for this seizure patient to help protect their airway?
Oh, an adjunct.
Okay. Which adjunct would probably be indicated in that situation?
I would have personally probably have tried to use an MPA just because it was hard. He was post-ictal. He was, you know, kind of
Okay.
moaning and
Well,
speaking.
yeah,
So if
because
I'd
he's
have,
post-sictal, he still probably
yeah,
has a gag reflex, and NPA
yes.
would absolutely be indicated in that situation. You don't see many people put in an NPA for a seizure or a stroke patient, but you always want to think, hey, is there a reason that they may not be able to protect their airway if they're post-sictal? They may not be able to protect their airway as well. So you just want to take, go from their nose to their earlobe, measure that, um, lubricate that with your KY jelly or whatever your lubricant is. And then, so which nair should it go in? Which nostril? Which side is it designed to go in?
It's typically the right.
All right. Ideally, it wants to go into the right side, or it should. That's the way it's angled based on the bevel of it. And when would it be contraindicated for an NPA?
Let's say facial injuries, basal skull fracture.
Nice. Okay.
Things like that.
So they were having a seizure, so they didn't have a head injury. The other thing for a seizure, especially if you find a patient like on the floor, you want to make sure you're immediately considering C-spine precaution. That yes, it's still a medical call, but they ended up in a position that's not a normal position. We don't expect to see them on the floor. So if they're on the floor, how did they get on the floor? Did they fall on the floor? Did they hit their head while they fell? So we always want to just kind of consider those things. I'm not here to critique what you did. I just want you to consider what's the best possible care that you could give this patient. Okay.
Absolutely.
All right. Cool. Let's go with Winchell. What kind of wins? You joined us earlier this week. Winchell, you there?
Yes, sir.
Oh, by the way, what do you think of
I
all
went
these
on. Yes, sir.
people
Can you
passing
hear me?
these tests left and right?
Hey, I'm happy for them. I want to be one of them.
Hey, you will be. All right. So, what's your win this week?
This week I scheduled my registry for August 28th, and I
Okay,
also
good.
purchased your 14-day immersion
Okay.
program.
Did you get the pro level?
I think I got the pro level.
Okay. All right. I didn't even know, but okay. So, and did you double check to make sure everything is unlocked because you were already a part of the school community? Sometimes it bypasses, like it doesn't register that you're a new person. So it may not have rerouted you, but just double check while we're on the call today. And before
Okay.
we end, make sure that you have access. If not, I can actually, my admin is gone for the day, but I know how to do that part. So I can get you access while we're here today.
I was just missing a part where it was asking for like a code, and I don't remember receiving a code.
Okay. Just stay on to the end. I'm not exactly sure what you're talking about. Just stay on to the end and we'll make sure that you get your access. Okay.
Okay.
But give
Thank you.
me another win. Like what else happened? What else did you learn this week?
I actually took the time yesterday, and I actually worked on the cranial nerves.
Oh, okay. How many are there?
Yeah,
How many pairs of cranial nerves are there?
12.
Okay, let's go. Since you want to go
12.
there.
You have olfactory.
Mhm.
You have the ocular motor.
That's number
Uh,
3.
number 3.
Mhm.
So what was the other
All right, so
one?
let's go. Cranial nerves, and this isn't something that always gets tested. It's just one of those things too. It's not so much that you need to memorize all of the pairs of cranial nerves, it's that you need to know what those nerves do. So that if you have, let's say, a trauma patient or even a serious medical patient, and they have some kind of neurological deficit, if you know how to assess
Mhm.
for the cranial nerve, then you can figure out, okay, is this nerve working or not? Just as a
Mhm.
part of a comprehensive assessment. All right, so let's do this really quickly. So we have, you see how I have to be prepared for anything? I never know what the questions are, but I'm prepared for anything that comes up, hopefully. So,
Mhm.
thanks. Okay, so our 12 cranial nerves. All right, so hit me. Number 1 is the what?
It was the olfactory.
Olfactory. So what does that control?
That's smell.
That's your sense of smell. Okay. You don't have to know details like where the nerve travels through, but the answer to that is it travels through the cribriform plate. The olfactory nerve travels through the cribriform plate right behind the nose. All right, what's cranial nerve number 2?
Of optic.
Optic. Okay, so what does the optic nerve do?
The optic would be vision.
That controls you being able to see. Yes. All right, so what's
Mhm.
the cranial nerve 3?
That's ocular motor. So that's like
Oculomotor. Okay.
that's
What does that
eyes
do?
moving.
It does
Yeah,
what?
eye moving.
Okay.
Your eye
Eye
moving.
movement in which direction?
I don't know which
That's okay.
direction.
So which three cranial nerves do eye movement?
I I thought it was 3. It was 2, 3, and 6. I believe
It's 3, 4, and 6.
3, 4, and 6.
Mm-hmm. Okay. Cranial nerve number 4. What's the name of that one?
The trochlear.
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 Trochlear. Okay.
Trochlear.
It moves a particular eye muscle called the superior oblique. Okay. Let's go to cranial nerve number 5.
5 would be trigeminal.
Trigeminal. Okay. So sometimes you'll see patients that have something called trigeminal neuralgia. Okay. Also known as tic douloureux. The trigeminal nerve. So here's a face, right? So the trigeminal nerve, actually, it's called trigeminal because it has 3 branches. So there's a branch that controls it goes to sensation to around the eye. It also goes to, there's a part that goes to like the facial muscle, sensation of the face. And I'm stressing that it's sensation and not movement. So sensation of the face. And then there's also a division that kind of goes toward the lower jaw. Okay. So those are the 3 branches. So how this shows up in a patient is, let's say they have trigeminal neuralgia. So if they have trigeminal neuralgia or tic douloureux, they have like this pain on one side of their face where they may have trouble seeing or feeling. They have loss of sensation around the eye. They also have loss of sensation to the upper part of their face and loss of sensation to the lower part of their face. Okay. So that's trigeminal neuralgia or tic douloureux. Okay. Let's go to cranial nerve number 6.
That's was it abduce?
Abducens. Yep.
Abducens.
Abducens. That does eye movement to what's called the lateral rectus. Okay. So let me show you a little trick. For the 3, remember there are 3 cranial nerves that all do eye movement. This is the way I remember this. LR6, SO4, 3. Kind of like a chemical formula. So cranial nerve number 6 does the lateral rectus. Cranial nerve number 4 does the superior oblique. These are muscles around the eye. And then all the other eye muscles are cranial nerve number 3. Okay. So lateral rectus is cranial nerve number 6, abducens. Superior oblique muscle of the eye is cranial nerve number 4, trochlear. And then all the other muscles that move the eye are ocular motor, cranial nerve number 3. So LR6, SO4, 3. Okay.
Okay.
4,
right. 3.
LR6. So LR6, SO4, 3. All right, let's go. Cranial nerve number 7. What does it do? Or what's it called?
That's facial.
That's going to be facial. So this is particularly facial movement. So one is like cranial nerve number 5 does facial sensation, you feeling things on your face. Cranial nerve number 7 is how you move muscles around your face. So when you do this stuff like this, okay, so when you make this kind of kissing motion, like you pucker up like that, you're moving muscles in the face. That's going to be the orbicularis oris muscle, for instance. You don't have to know any of this part. What you want to know is cranial nerve number 7 does facial expression and a condition associated with this. So let's go back. Let's go with a condition associated with cranial nerve number 5. That's going to be trigeminal neuralgia. Trigeminal neuralgia is a condition when that nerve goes wrong. The facial nerve causes the condition Bell's palsy. Okay, so Bell's palsy is an interruption in cranial nerve number 7. All right.
Okay.
Let's go cranial nerve number 8. What's that? Are you just saying this from memory or are you looking?
No, I'm saying it from memory.
Man.
That one
Okay.
one is
What's cranial nerve number 8?
I know it has to do with hearing.
It does. Hearing and balance. That's going to be vestibulocochlear. Cochlear. So we have a trochlear, that's 4, and vestibulocochlear. You ever heard of somebody having like a cochlear implant?
No, I had a question of somebody, and I forget what the scenario was, but they lost balance,
Yeah.
and it had to do with that.
So it's going to do hearing and balance, or hearing and coordination. Okay. So when you hear people talk about their equilibrium, or sometimes you'll hear people who have, let's say, Meniere's disease, or they have vertigo, they may have some kind of interruption in their vestibular cochlear sensation. Okay. So that deals with hearing and balance. So that's going to be cranial nerve number 8. What's cranial nerve number 9?
I know 10 is the vagus nerve.
Okay, let's put 10 as vagus. Okay, cranial nerve number 9. So I'm starting it off for you. Help me out. See if you can beat me. Okay, I got it.
Is it like something with swallowing?
Okay, it does.
Swallowing?
Okay, so that the name of the nerve is glossopharyngeal nerve. And the cranial nerve number 9 is involved with swallowing. It's involved in taste, and it's also involved in the baroreceptor reflex. Okay.
Yeah,
the baroreceptor reflex. When you hear somebody talking about we're gonna get somebody to bear down, to vagal down. Well, that's cranial nerve number 10 that gets involved, but also involved in the baroreceptor reflex is cranial nerve number 9. Okay, cranial nerve number 9 sends a signal along the from the carotid sinus along cranial nerve number 9, and then from the aortic arch, it travels along cranial nerve number 10. Okay, both of those are involved in baroreceptor reflex, which is how your body regulates your blood pressure. I'll show it to you in a moment. Okay, cranial nerve number 10 is vagus nerve. It's like a master nerve that controls a whole lot of organs. So it happens to be the longest nerve, and it innervates a lot of different organs, namely the heart. Okay, give me cranial nerve 11.
That's your accessory.
Okay, spinal accessory. It's the one that makes your head move. It also allows you to shrug your shoulders. So it activates the trapezius and the sternocleidomastoid. Okay, that's the spinal accessory, but it mainly allows you to move your head, shrug your shoulder, move your head and shrug your shoulders. Okay.
So I could just put head by there.
Okay. Well, it allows you to move your head in certain directions, but not all directions. And it allows you to activate the shoulder muscles to shrug your shoulders, because it's really a neck muscle that's pulling it up. Okay. And then what's cranial nerve number 12?
That'd be like your tongue.
Okay. It's the hypoglossal, gloss meaning tongue. It's the hypoglossal nerve that controls movement of your tongue. When you hear somebody, okay, how many of you ever been to the doctor and they say, stick out your tongue and say, ah? Okay. The stick out your tongue part is checking your hypoglossal nerve. The say ah part is checking your glossopharyngeal and vagus nerves. Okay. So when you hear a doctor say, stick out your tongue and say, it's not just something to say, it's actually checking cranial nerve function. Pretty cool?
Yeah.
Okay. So how would you assess for this in the field? We assess for generally everything with the exception of oculomotor. A great way to do this is like have a jar of like coffee beans. Unfortunately, they don't give us our coffee beans on the ambulance, so we skip that one. But we can assess for everything else. How do we assess for cranial nerve number 2? Look at the back of this ambulance and tell me what that shape is. Tell me what that color is. If I stick my fingers far out in front of your face, how many fingers am I holding up with one eye closed? That's how we assess that. Okay. How do I assess cranial nerve number 3? Cranial nerve number 3 assesses all but these 2 muscles. So this is the one where I'm going to have you like move from side to side. Well, actually side, like moving away, that's lateral rectus. But for instance, looking up, looking down, that's assessing your eye movement. Also, another thing is, follow my pin light or follow my finger. Keep your head still and only move your eyes. When they do that, they're assessing cranial nerves 3, 4, and 6. How do we assess cranial nerve number 5? Do you feel me touching here? Close your eyes. Do you feel me touching? Am I touching the right side? Am I touching the left side? Do these feel the same on both sides? Okay. This is especially important for head injury patients, major trauma patients, stroke patients. Now, it's not the first thing you do. The first thing you do is take care of life threats. But if you got some time, you've got a 20-minute transport, these are additional things that you can do. These would also be additional findings to assess and document. Okay. Let's go. How would we assess cranial nerve number 8?
Just kind of seeing if they can hear something, just kind of snap.
Well, the way we do this is we come from behind them and we put our fingers up to their ear, coming from behind so they can't see it. And we say, like, we just wiggle our fingers by their ear, behind their ear, and say, am I over your left or am I behind your left or right ear?
Could you make them stand up?
Well, in the ambulance, you're not going to have them like walking, doing laps or nothing.
I'm like in the house or something.
You could just have them stand up, take a few feet or walk a few feet, as long as there's no risk of them falling, to assess their balance and coordination. Okay. So in addition to the cranial nerve, what part of the brain controls balance and coordination?
Would it be the medulla oblongata?
No.
Would it be the pons?
No. Okay. So it's going to be right back here. What's that part called? That's going to be the cerebellum.
Cerebellum.
Okay. So cerebellum is also responsible for movement and coordination. Okay. So cerebellum is the back of the head, and that's the part that controls movement and coordination. Also, balance is affected there. So that part of the brain plus cranial nerve number 8, if one of those is wrong, it's going to affect movement and coordination. Okay. So let's go. All right. So cranial nerve number 9. Remember, I said stick out your tongue and say ah. The other thing you test for is taste, but we don't put anything in their mouth to say, can you taste this or not? But we can say, can you swallow? You'll see a neurologist at the hospital when you take a stroke patient, they give them a cup of water and say, hey, they're watching them swallow. They're actually assessing for cranial nerve 9 and 10. All right, spinal accessory. I want you to shrug your shoulders. I want you to turn your head all the way to the left over your shoulder, turn your head all the way to your right over your shoulder. That's assessing those nerves. And then hypoglossal nerve, stick out your tongue. Okay? Pretty cool? All right. You're just showing out for real. No, this is cool because this is a review. This isn't something I talk about a lot, but, I'm always prepared. All right. What other questions do you guys have? Let's go there. Any questions? Oh, Thomas raised a hand. All right. So,
yes,
Thomas,
sir, with cranial nerve number 5, is that the one that's involved if someone has trismus?
Say it again.
Cranial nerve number 5, is that the one that's involved if someone has trismus, the jaw's locked up?
Partially, and then mainly cranial nerve number 7.
Okay, facial nerve.
Because that deals with muscles of facial expression. So it's a combination. There is some overlap with 5 and 7. Okay. And for everybody, what is trismus?
Lockjaw, like you'd have to use a paralytic for, I would assume.
Okay. So trismus is where you just have kind of this grinding of your, well, trismus is more of the lockjaw. What is it when you grind your teeth? What's that called?
That I don't know.
That's called bruxism. All right, so trismus and bruxism. Bruxism is teeth grinding. Okay, trismus is more of the lockjaw. What's a toxin that can cause this lockjaw that we get vaccinated for? You still there?
Oh yes, that I don't know either.
Okay, that's tetanus. So when you hear them say, okay, have you had your tetanus shot? Have you had your tetanus shot in the last 5 or 10 years based on the age or based on what happened? So your tetanus causes lockjaw. Tetanus can cause this trismus. That's why we get vaccinated. This is why we say, okay, if you stepped on a rusty nail or if you had any kind of penetrating something that went into your body, we want to make sure that you're vaccinated against tetanus, because imagine when your jaw stays locked, it could be very difficult to breathe. Okay. What is it? So tetanus, what is it exactly? When you hear somebody say, okay, they got a tetanus reaction, what is tetanus? Wait, T-E-T. What is tetanus? Somebody take a stab at it. Because how many of you have heard of somebody having a tetanus reaction or they have a tetanus shot? You've all heard of that,
Tetanus
right?
shot, sure.
It's
Isn't it a
for-
bacterial
It is. So
that
it's
attacks the nervous system?
yes. So it is a bacterial infection from the bacteria Clostridium tetani or tetani. Okay. Now, this same Clostridium, you've heard of C. diff. So Clostridium, well, Clostridium, there may only be one S in it. I think it is just one S. All right, so Clostridium difficile, C. diff. This is the bacteria that causes the explosive diarrhea that stinks so badly. That's another bacterial infection. It's in the same family. They're both in the Clostridia family, but it's Clostridium tetani. That's the bacterial infection that causes the infection known as tetanus that can lead to lockjaw. Okay, so what happens is it actually causes a toxin get released that causes, we don't have to know all this, but the answer is it cleaves what's called the snare protein. It's just a specific name of a specific protein, but it's that specific protein that it cuts, and that's what causes the reaction. Okay, so when somebody steps on a rusty nail, they get this bacteria called Clostridium difficile. Let's mute everybody for a moment. Okay, so they get this. Let's go back over that. Somebody step on a rusty nail. They get that bacteria now gets into the bloodstream. What's the name of the bacterium? It's Clostridium tetani. What does the bacteria do? So if here's a protein, let's just say this is your protein. What it does is it just kind of cuts a portion of the protein. The particular protein is called the snare protein. It cuts the snare protein. It cleaves it. That's how it's called. They say cleavage of the snare protein. And the result of that is it causes lockjaw. Okay? So the way we have to treat it is we probably have to give them some kind of muscle relaxer to relax the muscles so they can open their jaw again. Because what closes the jaw? It's when the muscles come together. When the muscle contracts, it pulls up the lower jaw, and that's what closes the mouth. The upper jaw is fixed, but the lower jaw is what moves. Right? Does that make sense? So the lower jaw comes up, and that's what closes your mouth. So it's closure of the lower jaw. All right, I didn't even know we were going to go there, but that's cool. Okay, how did we get there? How did we get to Christmas? Where did he go? Thomas, how did
Still
we
here,
get
Coach.
there?
From asking about cranial nerve number 5, and then you explained that number 5 and 7 are both involved in trismus.
Oh, gotcha. Okay.
I did have another.
Okay, cool. Did that answer your question though?
Yeah, on that one, yes, sir.
Okay, what's your next question?
Well, I recently had a friend who tested, and he said he had the subject of SSRI syndrome or serotonin syndrome came up in his exam with those types of medications.
So serotonin, you're talking about serotonin syndrome?
Yes, sir.
Okay. All right. What's your question?
I'm guessing I should have asked him, because how would that actually come up in an exam? I mean, would it be like it's a reaction for SSRI drugs or something to that nature?
It could be. So now who takes SSRI? So first of all, what is an SSRI? What does that even mean? We can't be just using words up in here. We're not defining these words, bro.
Zofran, isn't Zofran a serotonin inhibitor? Like a
It
phenazine?
is. Now, Zofran is a 5-HT 5-HT receptor antagonist, or a serotonin receptor antagonist. In this case, this is not exactly that. But so what does SSRI stand for? What do these letters even stand for? So it stands for selective serotonin reuptake inhibitor. What does that even mean? Okay, so let's break it down. Let's say here's a nerve. All right, so here's a nerve, and here's a muscle. Okay. Now, so this first thing, this is a nerve. Let's talk about the parts of a nerve, by the way. So in a nerve, we have this kind of star-shaped situation up here. What's that part called? So what I'm talking about, this whole thing is called a neuron or a nerve cell. Okay. What's this first part up here, this star called?
Oh, is that the axon?
No.
No,
that's called the dendrite.
Okay, dendrite.
Okay. Then we have this kind of long section here, this long shaft. That's the axon or axon hillock. Oh. Okay. And then down at the bottom, this kind of button-shaped thing is called the terminal, meaning end. It's the terminal bouton. So anyway, we have a dendrite, we have an axon, we have a terminal bouton. Let's just say nerve. All right. So here's a nerve, though. So what happens is, let's say here's serotonin. Serotonin is a neurotransmitter. So let's just put SER for serotonin. Okay. So what happens is that serotonin ends up getting released out into this little space. What is the name of this space between the end of the nerve and the muscle? What's that space called?
Is that the synapse cleft?
It is. That's called a synapse or synaptic cleft. Okay. Okay. So what happens is the neurotransmitter gets released into the. Another way to say this is called the NMJ. NMJ. That's neuromuscular junction. Let's break that down. It's the junction, the space between the nerve, neuro, and muscle, muscular. So it's the neuromuscular junction. Also, it's known as the synaptic cleft. Okay. What happens though is serotonin is supposed to kind of leak out, so to speak. And that's what allows it to have some kind of effect. But then what has to happen is some of the serotonin has to be taken back up and go back where it came from. When it gets taken back up into the nerve, that's called reuptake. But if something inhibits it, if we have a selective serotonin reuptake inhibitor, we prevent it from being taken back up and going back into the nerve. So what it does is, instead of it being taken back up, where it's no longer going to have any effect, it just stays there. So let's put serotonin in red. Or actually, let's put it in pink so we can see it, or green. We'll put it in green. So here's serotonin that was first there. Some of it starts leaking out. But then it has to go back where it came from. Okay? But let's say it doesn't go back where it came from. We prevent it from being taken back up. Then where does it stay? It just stays here in the neuromuscular junction, and it keeps having an effect. So what kind of effect is it going to cause? If we have a whole bunch of serotonin that gets released in the gut, it's going to cause nausea. But for instance, in the brain, it can cause things like depression, but it can also cause a lot of sympathetic symptoms. And that's how we see it. So we're going to see all these kind of sympathetic effects where everything is up. So heart rate is up, blood pressure is up. So they have tachycardia, they have hypertension, they have agitation, they're amped up. Okay. Where else do we see this same kind of pattern where heart rate is up, blood pressure is up, they're agitated, they're sweating? Where else do we see this, like a similar situation?
Oh, we got thyroid storm?
Yeah, there you go. Man, check you out. Thyroid storm. Okay. So in a thyroid storm, they can have very similar effects to a serotonin overdose. Okay. Or serotonin syndrome. Now, if it's a tumor that's causing all of this stuff to happen, then we call that carcinoid syndrome. Carcinoid syndrome. Okay, let's go back over that. That was a lot. So in serotonin syndrome, it's where you have too much serotonin that gets released in the neuromuscular junction and it stays there. What's supposed to happen is some of it gets released and then it gets absorbed back into so it just gets released and then goes back where it came from. However, when you inhibit it, you prevent it from going back where it came from and it stays in the neuromuscular junction and it keeps causing all these effects. What kind of effects does it cause? Tachycardia, hypertension, agitation, violence, sweating, tremors, stuff like that. Okay? Now, so what are you going to do for it? Well, everything comes down to oxygenation, ventilation, perfusion. You ever heard this before?
Yes, sir.
So if they have, for instance, let's say they got an excess heart rate, excess BP, those are perfusion problems. So we're going to do stuff to bring down the heart rate, do stuff to bring down the blood pressure. Okay? All right,
Joshua?
now, say it again.
Speaking of this serotonin syndrome,
all right, who's talking right now?
Christian,
what'd you say?
I said, speaking of this serotonin syndrome, in my family's business is all about raves.
All about
music
what?
festivals. Music festivals and raves.
Oh, gotcha. Okay.
And one of the biggest things is people not being knowledgeable when they take like MDMA.
Okay.
Which releases a lot of serotonin and dopamine in the brain.
And then MDA is what you're saying, right?
MDMA, yeah.
Okay. 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 I know what you're saying. Yes.
Or Molly, yeah. And that releases dumps the whole bucket of all the serotonin and dopamine in your brain, and people will try and take 5-HTP afterward to help fill that serotonin in their brain, but they don't realize that if they do that too soon, then they're going to run into that serotonin syndrome, because now they're just trying to make their brain produce a whole bunch more when it already has a whole bunch going on. And some people even take it at the same time, and they're just not knowledgeable, and then they end up with serotonin syndrome, and they're not knowledgeable on this fact. And I see that all the time there.
And you're not going to always know, just because you're not going to have a toxicology report. So you're not going to necessarily know. What you're going to have to deal with is all the symptoms or the signs they're having. So you're still going to figure out, is it oxygenation, ventilation, or perfusion? It's a perfusion issue where heart rate's up, blood pressure is up, because remember our situation yesterday where we have, or this has come up many times, blood pressure equals heart rate times stroke volume times systemic vascular resistance. In this case, heart rate goes up, therefore blood pressure goes up. There's also some effect on the resistance. So there again, the blood pressure goes up even more. So what you're going to do is kind of manage the symptoms the best that you can. Now, go back to this one, though. What if so Thomas mentioned they may have a thyroid storm, and that could also produce similar symptoms. What would we do, especially if they're having a thyroid storm? Like, let's say they have a known thyroid problem, or they have Graves' disease or toxic multinodular goiter or something like that. What's our treatment of choice here?
Beta blocker.
Nice. Okay, it's going to be a beta blocker. And what specific beta blocker is the one we want to use if we can?
A selective beta 1.
Well, this one's going to be non-selective, but which one?
Non-selective. Okay. I'm not sure.
So non-selective doesn't choose beta 1 or beta 2. It just affects both of them. So this is going to be a non-selective beta blocker. And which one is the beta blocker of choice?
It's metoprolol came in my head, so I'm just gonna say that.
This one's going to be propranolol.
Propranolol, okay.
Okay, propranolol would be the drug of choice, or PTU, prothyrouracil. You're not going to have that. Like, this is something they'll have at the hospital. But propranolol, you may have it, but if you don't have that, another beta blocker could work. Okay. Any other? That was kind of a nice review. Hey, somebody, do this for me. Let's go, Bradley. Bradley.
Yes, sir.
I want you to tell me about serotonin syndrome. I'll even leave the picture up for you.
Oof.
Hey, don't start it with oof.
Sorry, Coach. So too much of an SSRI drugs can cause excess serotonin to be released from into the synapses cleft, and it can be up-regulated, and then that
it prevents it from being taken back up. Reuptake is where it goes back where it came from. But if you inhibit that, you prevent it from being taken back up. So instead, it stays here.
Okay. Yeah. So it's released, but it's being prevented from being retaken or retaken back
You
up,
prevent
and
the
then it stays.
reuptake.
Prevents the reuptake, and then it stays in the system. And too much of that is kind of what leads to the increased heart rate and blood pressure, and like similar symptoms to a thyroid storm.
Okay. And so how would we treat it? We'd treat it in a similar fashion to how we may treat a thyroid storm, based on your protocols, at least.
Treat it with a non-selective beta blocker.
Okay.
In this
Such
case,
as
it'd be
what would be the one
propranolol.
of choice?
Propranolol.
Okay. What's another drug that we would give?
PTV.
PTU.
I'm sorry. PTU.
Okay. Now you're hating on my handwriting.
Sorry.
Yeah, that's prothyrouracil. Prothyrouracil is PTU. Okay. All right. Does that make a little more sense?
Yes, sir.
Cool. All right. Now, how many of you? I'm just curious. Hey, Thomas, let's go to you for a second. Or you got Christian there, so that's fine. Christian, did you get this in paramedic school? Well, you probably did. Like, it's probably in your book. It just
the
wasn't
whole
emphasized.
transfer of the nerve and everything with the axon and all that stuff. Yes.
Okay.
Yeah.
But
as far as deep diving into what causes like afterward, like how serotonin syndrome is because it's the reuptake, and so much of it never dove into that at all.
Okay. And this little picture here of the nerve and the neuromuscular junction and the muscle, this is something that we'll use. The same picture, we would use it if we're talking about any kind of neurotransmitter. We could be talking about acetylcholine. We could be talking about, epi and norepi are hormones. Hormones and neurotransmitters are different, but they have kind of a similar effect. Hormone is the word that we use when we need a signal to go from one place to another place, like a long way away in the body. A hormone is what's used, and it sends a signal through the bloodstream. A neurotransmitter is like a close by. So if you're just going from this house to this house, a neurotransmitter will get you there. But if I got to go down the street or across town, I need a hormone to get me there. Okay. But it's really important to know this basic structure because it overlaps with so many conditions. We could just swap out the conditions, and now I could talk about Parkinson's disease. We could talk about they're just so all the neuromuscular disorders. We could talk about myasthenia gravis using this exact same picture. Lambert-Eaton myasthenic syndrome, Parkinson's, Lewy body dementia. We could talk about a lot of things with this one picture. So this is a great overall concept to know. The big concept that you want to know, the big picture concept, is you have a nerve, and like I said, the nerve, the neurotransmitter gets released through what's called a vesicle, through what's called a presynaptic vesicle. What does that mean? Pre meaning above or before. So if this little space is called a synapse, what's above the synapse is the presynaptic, and the little container that it's in, that's called a vesicle. So the neurotransmitter gets released from the presynaptic vesicle into the neuromuscular junction, and it causes a synapse or an impulse where the signal now goes to the muscle. But this is how all nerves and muscles work. Like, no muscle moves without input from a nerve. Let's say I call this muscle the diaphragm. Then the nerve is called the phrenic nerve. Okay? Or let's say this muscle is called the heart. Then the nerve is going to be the vagus nerve. But every muscle has to have some kind of nerve impulse. And then the other day, we talked about how muscles contract. Right, Christian?
Yes, sir.
2 days in a row, in fact. All right. Hey, Jen. Jen is there with us. Jen, are you able to turn on your camera? Jen or no? All right. So, hey, Becca, what questions do you have? I know we went off on the deep end.
No, all this was good. I have been keeping notes and writing everything down.
Okay.
This is great.
Okay, and the replay will go up, so you guys will be able to catch this in the replay.
Awesome.
Do you have any questions about any topic you want to go over? Like I said, I had no idea we were going to go over any of this, but I stay ready, so I don't have to get ready, right, Winchell?
No, I'm good.
Okay. All right. Who else? Any other questions? So we've got for those of you who are still with us, Jen is there, but I don't see
I
you.
have a
Oh,
question
Logan,
if
there you
you
go.
could, Coach. Yeah. Since we're doing the brain, could we do a little brain A and P? Because I do struggle with that, like the medulla oblongata and
Oh,
all of
wait,
that,
in the
the
wrong
cerebellum.
Let's go, man. My man says he wants brain, like he wants anatomy of the brain. Okay, so we're gonna go. Yeah, let's do it. Okay, and you notice I draw this kind of same picture over and over and over again. Okay, so let's start off. Let's actually start off at we'll start off at a macro level, a big picture level first. And so this is just kind of the overall orientation of the brain. Now this is a lateral view, so this would be the view from the side. So let's get us oriented. So this is the posterior view, so this is the back of the head. This is the anterior view, so that's the front of the head. And so, for instance, I'm now looking from the patient's left side. So this is a left lateral view. So this is a left lateral view. And we're doing it that way because that's the way I know how to draw it. Or we could flip it around and it'd be the opposite. But let's stick with this. So up here in the head, so obviously we've got the brain. Okay. Now the brain has different hemispheres. Okay. So this would be the left hemisphere of the brain. This would be the right hemisphere of the brain. This little part that I put, let's color code this. Let's put this in green so it stands out a little better. That little division between the left side of the head and the right side of the head, that's what's called the corpus callosum. That's called the corpus callosum. That's how the signal goes from one side of the head to the other side of the head. Because we need signals to go across because we need the arms and legs and stuff to move, okay? So that's, and then we'll go deeper into the brain in just a moment. But we have the front, so the brain has 4 essential lobes. This front lobe, that's called the frontal lobe. That part controls things like personality. You also have Broca's area here that controls speech. So that's going to be Broca, B-R-O-C-A. Broca's area that controls speech. So when somebody is having a stroke and they can't talk, what's the word for can't talk? They have aphasia.
Aphasia.
Now, there are 2 kinds of aphasia, by the way. What are the 2 types of aphasia?
I know one is expressive.
It is? What does that mean?
That's they're not, I mean, it's not necessarily they have an issue talking, they have an issue expressing their thoughts and feelings.
Well, yeah, but when they express their thoughts and feelings, that's talking, right?
Well, yeah, right.
Okay.
You're right.
So,
You're very right.
So this is mainly them being able to talk, like get out what they're trying to express, what they're trying to say. Okay. What's the other aphasia? That's called receptive aphasia. And this is where they have a problem understanding. So this one is not being able to talk. The other one is not being able to understand. They're not able to receive the message. Okay? But especially if they can't talk, we have a high suspicion that Broca's area just got wiped out. Okay? So it's over here kind of in the front on the left. That's Broca's area. That's the frontal lobe. So personality, speech, things like that. Agitation, stuff like that. Emotions. Then we also have the, here, actually, let's do this part kind of from the top. Let's just do let's do it like this. And so this is the anterior and this is the posterior. So here's our frontal lobe. Then we have our, we kind of, this region here, we have, what's that called?
Temporal.
Well, the temporal is a little further to the side. So the temporal is going to be over here.
Call them parietal.
So these are our temporal lobes. Then we have the parietal lobes. Then we have what's in the back?
Occipital.
That's our occipital lobe. The very back part of the head, that's the occiput. Okay, so those are the four main lobes of the head. Okay. Now, another thing to know. So let's put in our frontal. Really, frontal should be up here. So frontal, then we have your, what, I put it in green. So we've got our parietal lobes. Then we have our temporal lobes on both sides. Then we have the occipital lobe. Okay. Now, that makes up the brain and the cranial vault. Then we have this brain stem part, which is, oh, well, first of all, before I get to the brain stem, this part right here, this is the cerebellum. So let's put that in orange. This is our cerebellum. We already talked about that. What does the cerebellum do?
Movement and coordination.
Movement and coordination. Okay, that's the cerebellum. Then we get to this other section. That's our brain stem. So we have three main divisions of the brain stem. The first part, what's this? So I'm going to label them 1, 2, and 3. What's section 1 called? All right, section 1 is going to be called the midbrain. Okay. What's section 2? This is the pons. And then what's section 3?
The only one left, medulla.
That's going to be the
oblongata.
medulla oblongata. Okay. Now, what does it do? Well, cranial nerves run through here. So we got a lot of cranial nerves that kind of course through here. So if you damage your cranial nerves, or if you damage your head, you could also damage your cranial nerves. So whatever those nerves are supposed to do is not going to do that. Okay. The other thing you have here is you have your respiratory center is here. This is where your main center that makes you breathe. It's located in the medulla oblongata. Also, there you have chemoreceptors that detect your CO2 or lack of oxygen that makes you breathe, which is also there again a part of the respiratory center. The other thing we have here is baroreceptors. So we have chemoreceptors that are involved in breathing. We have baroreceptors that are involved in regulating your blood pressure. Baro meaning pressure. Okay. So that's kind of the overall view of that. And then of course this brain stem further leads down into the spinal cord. Okay. Now let's go into the spinal cord. Okay. So the spinal cord. So there are nerves. Let's put nerves in orange. There are nerves that course off along different parts of the spinal cord between the vertebrae. Okay. How many vertebrae do you have?
26.
Okay. So it's like our Jesus number.
Lunch and dinner, or yeah, that one too.
Okay. It's like
Breakfast,
our
lunch, and dinner
Jesus
was
number. All right. So 33. Okay. So we have 33 pairs of vertebrae. Now, what are they? So remember, so the way I remember this is you have breakfast at 7, lunch at 12, dinner at 5, and then we have 5 and 4. So we have 7 cervical vertebrae. Hey, add that up and make sure that's 33. 7 and 12 is 19 plus 10 is 29 plus 4 is 30. Yep, that's 33. Okay, so we have 7 cervical vertebrae. We have 12. What comes next?
Thoracic.
Huh?
Thoracic.
We have thoracic. 12 thoracic vertebrae. Then we have 5 what?
Sacral.
Not yet.
No, we're not sacral yet. We're at lumbar.
Lumbar. Okay, just go straight down the. All right, so look from the body. So we got up here at the head, that's cervical. Then we get to the torso, that's thoracic. Then we get to the lower back, that's lumbar. Then we get down to the butt area. So what's that?
Sacral.
So we have sacral, And then what's the final vertebrae that are kind of fused together?
Coccyx.
Coccygeal, okay. Coccygeal. Okay, those are your pairs of vertebrae. So 33 pairs. So you have 33 on the right, 33 on the left. So 33 pairs of vertebrae. And all of those make up the spinal cord. Okay. Now, going down the spinal cord between all these vertebrae. So let's just draw it like, I'm gonna just do a rough sketch. Let's say I'll put it in gray to kind of mimic, well, it's kind of a whitish gray. We'll put it in gray. So let's say here's a vertebrae. It doesn't look quite like that, but something like that. Let's just say this is our vertebrae. Well, between each vertebrae, there's this kind of cushion because you don't want bone rubbing against bone, right? So there's this disc between. So let's break that down. If you put a disc between a vertebrae, the word for between is inter, disc is disc, and vertebrae is vertebrae. So put all that together, intervertebral disc. So this little disc here is the intervertebral disc, okay? So if you hear somebody, they say they have a herniated disc, that means the disc has like kind of eroded. It could be due to arthritis, osteoporosis, injury, a viral infection, whatever. Lots of things could do it. Bamboo spine, let's say they have some kind of... Lots of things could do it. Now, this in the center of this disc, there's this kind of like a jelly-like substance between, like in the center. So I did disc in purple. So let's do a disc. This is a disc. And then there's kind of like this little shock absorber stuff in the middle. So I did that in red. It's kind of like this little jelly-like stuff. This is how signals transmit from one vertebrae to another. This is how the nerve is able to flow through. That little thing here is called the nucleus propulsus. You don't have to know that. That's the nucleus propulsus. What you do care about, though, is you have the different vertebrae, and then the thing between each vertebrae, or vertebra, if you're talking one, is the intervertebral disc. But if somebody has a herniation, so let me show you what it would actually look like. A herniation is where we have this kind of situation. This disc starts like oozing out here. That would be a herniated disc. Okay, so you've heard those kind of terms before, right? Somebody such and such, they have a herniated disc. What we're saying is the intervertebral disc is kind of oozing out of the space that it shouldn't be oozing out. It should only stay between within the vertebral column. Okay. Now, let me go back to let's go back deeper into the brain though. So here's your brain. Okay, so the way it works, these are structures that you may or may not have heard of before. This very first thing up here, this is going to be called the cingulate gyrus. We'll skip that part, but it's the cingulate gyrus. Then we have the corpus callosum. I think I drew that in a green. We have the corpus callosum. This is the little part that allows signals to go from one side of the head to the other. That's the corpus callosum. Then underneath that, we have what's called the thalamus. Okay. Now, why do you care about stuff like this? Because, for instance, let's say somebody knocks out this part of their brain called the thalamus. What does the thalamus do? Anybody know?
Receive signals from the body.
Nice. Who's talking?
It's me, Thomas.
Thomas, nice, man. Okay, so the thalamus is like the relay center for the body. So all these signals that end up in the brain that travel from the spinal cord or somewhere else in the body through the spinal cord to the brain, the relay center, the control center, the dispatch center is called the thalamus. So this is where all the messages they come here. So like a message may come here, then it goes to the thalamus, and then it goes to wherever it needs to go. So the relay center is the thalamus. But let's say somebody has a seizure right here. Let's say you have too much depolarization. These cells are getting really positive, amped up, and it's causing a seizure. This particular seizure is what we call what was formerly called a petit mal seizure, or one of the types of generalized seizures called an absence seizure. So absence, spelled like absence, pronounced absence. So this is the little kid that's just staring off in space, and they're having a seizure. They're having a seizure right here in their thalamus. That's called a thalamic seizure. Because this type of seizure is different than other types of seizures, we treat it differently. So if somebody's having an absence seizure, we treat it with a calcium channel blocker known as ethosuximide. Okay, which behaves like a calcium channel blocker. All right, now let me get back. So we have the cingulate gyrus, then we have the corpus callosum, then we have the thalamus. Below the thalamus, under thalamus is hypothalamus. So let's put in hypothalamus. Okay.
Doesn't the hypothalamus and the thalamus send signals to release hormones in the body?
Yes. Primarily the hypothalamus more than the thalamus.
Yeah.
Primarily the hypothalamus sends a
that.
signal through from hypothalamus to pituitary to the organ. Okay, so the hypothalamus, what does it do? What does this thing do?
Doesn't it like talk to your endocrine system or like give out commands?
Okay, so hypothalamus. So it's called hypothalamus because hypo means under, and it's under the thalamus. So hypothalamus, what does it do again? So we said hormone regulation. That's a big job.
Issue commands. Okay, right.
What else?
I think it does that, and then other vital areas of the body. I just drawn a blank right now. I know
Okay,
it's supposed
so
to
it does. It's involved in temperature control. So a newborn baby who's just born, their brain is not developed. Their hypothalamus is not developed. Like they just came out of the womb. So they're not able to regulate their own temperature. That's why you have to warm. That's why one of the highest priorities for a newborn baby is to keep them warm, keep them dry and keep them warm, and put that little hat on their head so that you don't cause all this heat loss because their hypothalamus can't regulate their own body temperature. So it's temperature control, blood pressure control, sleep, and wakefulness, like how alert you are, stuff like that, sexual excitement, anger. Hypothalamus is involved in all of that. So if somebody has a hard enough head injury and it affects their hypothalamus, look at all the things it's going to affect. Okay?
So does caffeine affect your hypothalamus?
It can.
For wakefulness? Is that where it affects it?
Yeah, I mean, caffeine is going to travel throughout the bloodstream, so it's going to affect everywhere. Like it's going to have some effect on the heart. It's going to have some effect on the respiratory center, some effect on muscle contraction. It's going to have an effect on lots of things. Okay? Because it's going to travel through the bloodstream and work everywhere. All right, so then you have a hypothalamus. Oh, what else is really important in the brain? That's going to be your pituitary. Let's give me another color here. Let's go with, let's do like this blue. All right, so here's your pituitary. You have an anterior pituitary and a posterior pituitary. What do they do? So let's zoom in on this bad boy. You ready? Let's zoom in on the pituitary gland. Are you guys good if we keep going or no?
Yes, sir.
Okay, let's go. Let's go pituitary. Since Logan wanted to ask this question. No, I love it.
Well, I'm loving it. I'm loving it.
Are you though, for real? Don't fool me now.
Yeah. I always struggle with the brain, so that's why I asked.
All right, let's go. So let's go. Anterior pituitary, posterior pituitary. What do each one of these do? Here's the way I want you to remember it. B. Anybody ever played music? Any musicians in the audience? Okay. Well, you know, there's a musical note like a B flat, right? Play in the key of B flat. Well, I want you to remember, let's say we're playing, so I'm actually a saxophonist, believe it or not. And so let's say I'm playing the sax and I'm going to go ahead and play B flat. Well, so I want you to remember B flat. Now, why did I say that? So that B flat acronym is what we're going to use to know the hormones that the anterior pituitary controls. That's going to be, so the B and then flat. Okay. B is certain basophils. Basophil, it means that it stains, like when you put it under a microscope and you stain it, it looks blue. So it does some kind of different it has basophilic staining. But what the hormones specifically, the F stands for FSH, follicle stimulating hormone. Okay, that's the hormone that's responsible for making estrogen. So FSH. Then we have LH, luteinizing hormone. That's the hormone that helps create the placenta and also make progesterone. All right, we have ACTH, adrenocorticotropic hormone, that helps regulate the adrenal gland. Okay, adrenocorticotropic hormone. And then thyroid stimulate. No. This is actually thyroid releasing hormone. Thyroid stimulating hormone comes down in the thyroid. So this is thyroid releasing hormone. Okay? That's what gets made in the anterior part. Let's put posterior in a different color so that we don't confuse you. Let's put posterior here. The posterior pituitary controls, hold on. Oh, vasopressin and oxytocin. What does vasopressin do? Well, think about it. Let's break down the word. Vasopress. It squeezes blood vessels, so it helps to regulate your blood pressure. So that's vasopressin. What does oxytocin do? Oxytocin, somebody know? Before I tell you.
Uterine contractions.
Say it again.
Like if they're if a woman's breastfeeding after birth, it stimulates to release oxytocin to for uterine contraction, stop bleeding.
So oxytocin does milk letdown or milk ejection. So actual breastfeeding, the milk coming out, that part is oxytocin. But what's the hormone that makes the milk?
I don't know, Coach.
That's going to be prolactin.
Okay.
Because it's pro or in favor of lactation. Okay. No problem, Becca. This will go up in the replay. All right, no problem. So let's go over that again. So the anterior pituitary, the way you want to remember that is B flat. Basophil, follicular stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, and thyroid releasing hormone. Okay, those are all the hormones that are regulated primarily by the anterior pituitary. The posterior pituitary is going to make vasopressin and oxytocin. What does oxytocin do? It's responsible for milk letdown or milk ejection, and also it's responsible for uterine contraction. Man, I don't think anybody else has gotten all this. You guys are special. Okay. Logan, how you feel about that?
I'm feeling pretty good about it now. I mean, I like how it was broken down and stuff. The only other thing is you did say earlier about how the medulla is the respiratory center.
Yeah.
When it comes to the midbrain and the pons, could we go through what they control, or is it the?
Okay.
I mean, I should know that. Don't get me wrong, but I really struggle with the brain.
Okay. The biggest thing here is that different cranial nerves are going to exit different parts along the brainstem. In fact, let me just actually show you a picture of this. Stand by for one moment.
Gotcha.
Let me actually show you a picture here. let's go to, hold on. But is this helping so far?
Yeah, actually, I feel like I know a lot more than I did before, especially with your pictures, because I drew them out while you were drawing them out. So hopefully, I mean, like the other day, that information should stick.
All right, here we go. This is actually a pretty good one. Let's see. I'll pull it up in just a moment. I'm just trying to. I don't have a good picture pulled up for you. Oh, well, that's not a picture. That's just in words. And anyway, what you want to know, so I'll show you what I'm looking at. But so, like, if you look right here, let me go back up. So there's kind of this rule of 4 that we use. So essentially, let's skip to where. All right. So 4 cranial nerves in the medulla, 4 in the pons, and 4 above the pons. Okay. Obviously, you're not going to be able to tell. It's not like you're going to necessarily be able to look at the patient, but what you are going to be able to tell is what signs they're having. So depending on what deficit, that tells you what cranial nerve is involved. But it's not like you're going to be able to figure out, is it coming from the midbrain, the pons, or the medulla? But the way you kind of want to know this is cranial nerves 1 through 4, essentially. Cranial nerves 1 through 4 are kind of exiting above the pons. Cranial nerves 5, 6, 7, and 8 are exiting at the level of the pons. And then 9, 10, 11, and 12 are exiting below the pons, so at the medulla oblongata. So let's do it this way. Let's just write it in simply as we have basically cranial nerves 1, 2, 3, 4 are exiting in kind of this midbrain area. Now, when I notice I'm saying exiting, that's not where they start. They have an origin place and then they have an exit place. The ones that exit at the level of the pons are cranial nerves 5 through 8, and then cranial nerves 9 through 12 exit at the level of the medulla. But you're not going to be able to like tell that in real life. Like the only thing that you're going to be able to tell is you're going to be able to tell what kind of problem is this patient have. Okay, so if they have a problem where they can't hear, okay, well, the vestibulocochlear nerve probably got affected, so cranial nerve number 8. But you're not going to be able to necessarily tell that it was the pons. Now, where this does come into play is when you're talking about certain arteries. There are certain arteries that supply the brain. That's beyond the scope of what you need to know. Did you ever learn something about the circle of Willis?
It sounds a little familiar, but I don't really recall.
Just in the interest of time, just look that up. But there's certain. I actually have a picture of this in the Coach Joshua's drawing study guide. But here, let me just, since I don't have an actual picture pulled up right now, let me just Google it. So this right here. So this thing right here. Can you see what I'm doing? Can you see my screen?
Yeah.
Where'd it go? Where'd it go? Let's go back to this. Here, let's do images. Okay, here we go. So this right here. This is called the circle of Willis, and it's the blood supply. I'm trying to find. Can you see this one right here? You see where my mouse is? Okay.
I can't read it, but I can see the image.
Okay, so this is what's called the circle of Willis. This is how blood flows into your head. The biggest thing you want to know about blood flow in the head is the way God created us. It's so phenomenal that the reason it's so difficult to have a stroke is you have blood supply coming from multiple different angles. That's called collateral circulation. So let's say this side of the head gets knocked out. The body says, hey, I got another way to get blood there. I got another route that I can take to get blood there. That's called collateral circulation. And these different blood vessels, they also course or follow along certain parts of the brain stem. So when you have let's say you have an occlusion or a blockage in one of these blood vessels, then that can also cause certain symptoms. Like for instance, let's say you have this part right here, these arteries, these pontine arteries. Well, they're called pontine because they're in the level of the pons. But if let's say you knock these out, then it could cause things like pontine syndrome or locked-in syndrome. This is where the patient is like locked-in syndrome is where they're able to like move their eyes, but they can't move their body. They can hear everything that's going on. They're tracking with you, but they're like locked into their body. It cannot move. So that's locked-in syndrome or pontine syndrome, where you have a blockage in certain blood vessels. That's beyond the level that you need to know really for here. I could go so much more in depth, but it's way beyond what you need to know at the paramedic level.
Gotcha. I appreciate it. Thank you.
Sure. No problem. Did you have any questions about anything that we covered so far? This is a pretty cool image.
No, I really like that. I drew that almost verbatim, so it really helped. I appreciate it.
Yeah, I would actually recreate it. Just take a blank sheet of paper or iPad or whatever you use and see if you can recreate that. So let's review what we talked about. We talked about the different lobes of the brain. You've got the frontal lobe. You have the parietal lobes. You have the temporal lobes. Then you have the occipital lobe. Okay. You also have the cerebellum. We talked about the brain stem. So you have the midbrain, the pons, the medulla oblongata. Different things flow through there. So different cranial nerves kind of flow through here. Different arteries flow through there. You've got different veins that flow through there. So different veins, arteries, nerves flow through there. We talked about aphasia. We said there's one type called expressive aphasia where you have trouble talking. Then there's receptive aphasia. That's where you have trouble processing information or receiving or understanding stuff. Okay. We talked about the different vertebrae along the vertebral column. We talked about how many vertebrae you have in each area. We also talked about like how it's made. So between each vertebra is an intervertebral disc, and there's this nucleus propulsus between it. What else we covered? We covered the big structures in the brain, like the cingulate gyrus, then the corpus callosum, the thalamus, the hypothalamus, the anterior and posterior pituitary. We talked about what the hypothalamus does. So hormone regulation, temperature control, blood pressure control, sleep and wakefulness, sexual excitement, anger. The anterior posterior pituitary, it regulates lots of hormones. The anterior ones are our B-flat hormones, so that's going to be the basophils, so they stain blue. But the hormones specifically are going to be the follicle stimulating hormone that makes estrogen, luteinizing hormone that does the placenta and progesterone, adrenocorticotropic hormone that regulates what your adrenals do. So the adrenals make all kind of hormones, but the master thing for that is in the hypothalamus. And then thyroid releasing hormone is also made in the anterior pituitary. The posterior pituitary does vasopressin and oxytocin. Oh, let's go one more. The anterior pituitary, the other fancy name for that, anybody know? What's the fancy name for the anterior pituitary? All right, that's the adenohypophysis. Or adenohypophysis is the anterior pituitary. And the posterior is the neurohypophysis. Okay? So we have an anterior pituitary, also known as an adenohypophysis. And then we have a posterior pituitary, also known as a neurohypophysis. Now, man, so Logan, you go around the station saying stuff like neuro and adenohypophysis, people are going to be looking at you like, what kind of paramedic are you? What you smoking? And can I have some of it?
Yeah.
Okay, well, how are you feeling about all this?
Yeah, I'm feeling really good now. I mean, I can feel like I actually have something I can go off of here instead of just reading
Hey,
from
Cody
like
just
a
joined
text.
us. I just saw you, Cody. How you doing? I'm sorry to cut you off, Logan. So you feel like you
No,
have
you're good.
something to go on? You can kind of draw the pictures for yourself?
Absolutely, yep.
Okay.
Yep.
I'm
What
doing
what'd
good,
you
man.
like about tonight?
My favorite, what I liked about tonight, I mean, I learned a lot about the cranial nerves, that's for sure. I actually hadn't gone into that much, so that was very helpful for me.
Okay. And
And then the
inside the
brain obviously
program,
helped.
if you go to the 14 days program at the very top, there's this thing that says like read here. I forget what it says, resources or something like that. There's a list of like a whole bunch of documents, PDF files and stuff like that. One of those is cranial nerves.
Gotcha.
All right. Have you seen that before?
I've seen the resources. I don't know if I've seen the cranial nerves one. It's
All right,
probably
so
'cause I
look,
haven't
let's
gone
find
that
it.
deep into
So
it.
we're going to go, I'm in 14 days program. We're going to go to read first, introduction and resources. And then we're just going to scroll down cranial nerves.
Gotcha. Okay.
Okay. All right. So that's in
Awesome.
there. This was actually a good recap. Jen, you asked about trigeminal neuralgia. We actually already talked about it today. So what I'll have you do is just go back over the replay because we literally talked about it today when we were doing cranial nerves. And I mentioned cranial nerve number 5. Would you guys agree? Would you all vouch for me? Somebody say yes.
Yes.
Yes,
Okay,
Coach.
so they said
Yes.
yes. We actually did cover that today. So just catch it in the replay. Any other questions, guys?
Yeah, I have a question.
What's your question?
As I'm going through my 14 days, I saw somebody, I forgot his name, ask you about a book that you had that looked really cool that you keep on your person at all time. Do you?
This one?
Yes,
Okay.
that is the one.
Okay, guys, we definitely need to go ahead and get these made because we don't have any more, but we haven't had any more for months. But I've gotten asked probably 50 something times now. We probably should just go ahead and do this. But this is the little flip chart, the Level Up Medic flip chart that we did. So it came, there's cardiac arrest checklist, a post arrest, a ROS, stuff about abnormal heart rates, intubation, ketamine, fentanyl dosing. But let's just show you kind of what's in it. And so this was the one I carried in my leg pocket. So I have like a fentanyl dosing chart. So very quickly I could just say, oh, boom, based on my concentration, how much do I draw up very quickly based on based on the patient's weight. Or like so there's a ketamine chart in here. I literally have a little drawing of how to mix up an amiodarone and a norepi drip and stuff like that. And I really did use this in real life. This was my own personal copy. Epi drip, push dose epi. And I have little pictures because I can just look at the picture and I'm like, oh yeah, how do I mix up an epi drip? Because think about it, for most people, you're not mixing up like an epi drip every day, right? And so the last thing you want to have to do is look stupid in front of everybody. So you just pull out your little flip chart, go to epi drip. Oh yeah, okay, I need this, boom, got it. I literally have it down to like what size drip set you're going to use. So here we'd use a 60 drip set and that kind of thing.
Cool.
We do need to probably just get some more of these. We don't have them right now, but we've been asked about them a lot.
Okay. Awesome.
Okay.
And then my last question is, you just told somebody else who had to leave earlier that they could watch the replay. If I ended up missing one of these, where would I find the replays at?
Where would you find where you been, man? So right.
Well, I haven't missed one yet.
Okay. So under the 14 days program, the same is also true for the like if you're an EMT student, you can just access it in the free training videos. Some of them go there. Most of them go there. But under the 14 days program for you, scroll down. So you have cohort 1, cohort 2, cohort 3. First week or the final week before your exam. And then under that, it's the office hours, live sessions, and replays.
Awesome.
And you can go back and watch all of them. All of those videos are there.
Thank you.
What else?
That's it.
That book.
Yeah. Who's talking? Cody. Okay. What you
Cody. That book you just showed, would you be able to put that online as like a PDF or something, scan it so we can look through it?
Let me see what we can do because wait, what were you saying?
All right. Just like it'd be nice to have.
You like that?
Yeah, I want that in my pocket.
Okay.
Sure.
What would actually be good is for you to have the physical one because then you can just like carry it with you. and it always works. What I like about this is I can take a Sharpie, so I can take a permanent marker and write on it, and it erases well. It's just laminated paper, but it erases with a alcohol prep pad. So you can take an alcohol wipe, it erases very well, or you can use a dry erase marker. No. You don't want to use a dry erase marker because it's very easy to wipe off, but you can use a grease pencil. Hey, hang on one second. I have actually a paramedic calling me, but I want to make sure it's not a patient. Stand by. Hello? Hey, I'm actually in a session. Okay, so I was making sure it wasn't a patient. Okay. 2-month-old cardiac arrest? Oh, wow. Okay. Yeah, all right. We'll talk about it. All right, bye. Oh, wow. Okay, so it's not a live patient now, but it was a patient last night. Wow, and it didn't end well. Okay, so there was a question about Boerhaave syndrome versus Mallory-Weiss. Okay, so, all right. Jen is asking that question. What's your actual question? You just want to know what is each? Okay. And so, Jen, if you could, I don't know if you're able to unmute, but that would help me. So both of these situations, so whether we're talking Boerhaave syndrome or Mallory-Weiss, what structure are we talking about?
The esophagus.
Okay. So these are kind of so you know how you have so let's look from the side view. Let's look from the left side. So we have the trachea that kind of branches off and then it goes off into the different lungs, right? And then right behind that, we have the esophagus that goes into the stomach. Okay. Okay, Jen says she's in the truck, headed back to the station. It's really loud. We won't be able to hear her. But what's the difference? Okay, so you guys tell me. I mean, I know the answer, but I don't want to just give you all the answers. So what is each of these situations?
I believe Mallory-Weiss is caused by excess vomiting. Like somebody forced themselves to vomit, and it basically creates like a small tear in the esophagus, which could eventually bleed. And like a Boerhaave syndrome is like a complete tear in the esophagus.
Okay. Who is the patient who's likely to get one of these or either of these?
Like a bulimic patient, somebody who makes themselves vomit.
Okay.
Or alcoholic.
There we go. That's what I was looking for. So, so say it again. Summarize that again for me. I think you were on the right track, but sorry. Summarize that again for me.
I was thinking that the Mallory-Weiss syndrome is caused by excess vomiting that can eventually create like a lac or tear in the esophagus, and like Boerhaave syndrome is like a complete tear or separation of the esophagus. Yeah,
but how are you going to tell the difference practically? Like a GI doctor will be able to put a scope down, and with a scope, with a camera, they'll be able to see the esophagus, right? But functionally, how are you going to tell the difference?
I think with the hole, like somebody can swallow food contents, it can end up in the wrong place in the body, right?
Okay, but I mean, how are you going to practically tell the difference between Boerhaave's and Mallory-Weiss?
That I'm not sure on, Coach.
Okay.
I think it's the amount of blood being vomited. Like Boerhaave's is a serious amount of blood. The other one isn't.
Okay, I wouldn't think of it that way. Both of them could have. It depends on the size of the hole. It depends on the size of the rupture. As far as practically what you're going to be able to see, you may not actually be able to tell the difference. I mean, that's more of a theoretical kind of textbook thing. And a pathologist or like a GI doctor with a scope, they're going to be able to tell more functionally. But the biggest thing that you want to know is, yes, Mallory-Weiss is where you have so you have a tear. We're specifically talking about the esophagus. Both of them can cause significant bleeding, okay? What is the word for if you have bleeding coming out of the mouth? Like if you're coughing up or throwing up blood, what's the word for that? Or actually, those are two separate words. What's the word for coughing up blood? Is somebody saying it?
It's the tip of my tongue. It's not coming out.
Okay. The word for coughing up blood is hemoptysis.
Hemoptysis.
And what's the word for vomiting blood?
Hemoemesis.
Hematemesis. Okay.
Oh, close.
Oh, it's good, man. Good.
Hematemesis. Hematemesis. Okay. Hematemesis is where you're vomiting blood. Hemoptysis is where you're coughing up blood. So this, we would call this a GI bleed. Obviously, since it's coming from the upper end of the GI, this is going to be an upper GI bleed. Now, in an upper GI bleed, in fact, I should do the colors differently. Yeah, in fact, let's change these colors around because that wouldn't match actually. In an upper GI bleed, you're going to have, what's the color of an upper GI bleed?
Which
Like coming
part is
out
it coming out?
Huh?
Yeah, which direction?
Yeah, yeah. What direction is it
Oh,
coming
okay.
out,
I'm
Coach?
sorry. If it's coming out of the mouth.
I imagine it'd be bright.
Okay.
Yeah,
in the
bright.
mouth, coming out of the mouth is probably going to be like a bright red. Okay. But what if it's coming out of the butt?
Dark, tarry.
Okay.
Stools.
So if it's okay. Oh, I like that. I actually like how you said that. Dark, tarry stools.
Digested.
What's the word for dark, tarry stools?
So hematochezia.
Uh-uh.
Or is that
Melena?
the
Okay.
oh, Melena, yeah.
Okay, Melena.
That's it.
Okay, so that's dark tarry stools. On the other hand, what if this blood gets oh, and by the way, why is it dark?
Gone through the GI tract.
Say it again.
It's like been digested partially.
Yes. So this is where it's already gotten digested and made it through the GI tract, so it's going to eventually come out the other end. And it's going to come out the other end as dark tarry stools. So that's melena. Okay. Now, what if it really is from like esophageal varices or something where you have bleeding specifically from the esophagus that never gets digested? If it comes out the stool, what would it look like?
Would still be bright red then, right? Or that'd be a lower GI bleed.
Okay. So specifically, if it's coming from upper, like if the origin source is from an upper location, then that's going to kind of manifest. It depends on whether or not it's been digested. But if it does not get digested and it just comes straight out, then it's going to be more of a bright red blood. And what's the word for that? I think somebody said it already.
Oh, is that hematochezia?
Yes,
What I said earlier?
hematochezia.
Okay. Chezia, excuse me.
Okay.
So you could still have an upper GI bleed that comes out bright red.
Yes, it just depends on whether the blood is digested or not as it goes through the GI tract.
Hmm.
I was trying to see if I could find a picture of a. Some of these look hideous. Let's see.
I never knew that. I thought lower GIs were the only ones with bright coming out.
Well, because the blood has to go somewhere. It can just strictly come out of the mouth. But as this blood continues to accumulate, it's got to go somewhere. Some of it may just end up like spilling out into the abdomen. Some of it can end up being absorbed through the GI tract. It just depends on how much digestion occurs or not. There again, you're not going to always be able to tell this kind of stuff, right? What you're going to recognize is the patient's bleeding. They have signs of internal bleeding. They're probably going to have signs of shock, so they have hypo or inadequate perfusion. So let me just make sure I summarize this so that we're all on the same page. The way I want you to remember the way I want you to know, Jen, a Mallory-Weiss tear is, I think Christian was kind of onto it when he was talking about, it basically comes down to the mucosal layers. So let's draw it this way. Let's here, let me get some space here. Let's put it in like this. So the esophagus has striations, right? It has this musculature, because that's how the food is able to actually, like when you swallow, that's how it actually makes it down the esophagus. Muscles have to kind of push it along. By the way, what's the word for that when the muscles help push the food along? What's the word for that?
Oh, it's too bad. Went over that once in Mexico and I forgot it.
I'm writing it. peristalsis.
Oh, peristalsis.
Okay, so peristalsis is where the muscles kind of push the food along. But this is not completely smooth. Otherwise, it would be hard for you to get food to make it down this esophagus. The biggest difference with a Mallory-Weiss tear is it's more of like a partial thickness tear. Okay, versus in Boerhaave syndrome, it's more of like a full thickness tear. Does that make sense? So Boerhaave syndrome, more of a full thickness. You're tearing all the layers of the mucosa, of the esophageal mucosa. That's Boerhaave's. And then Mallory-Weiss is more of a partial thickness tear. Both of them are dealing with the esophagus. They can be, the patient is going to be more of like, it could be somebody with some kind of eating disorder like anorexia. It could be bulimia. It could be chronic alcoholism. Lots of things could do it. Even antacids could do it. Caustic substances. I mean, there's a lot of things that could do it. What you really want to know is just partial thickness tear is Mallory-Weiss. Full thickness tear is Boerhaave's.
Coach, what would treatment be if you had a patient with an active bleed and like that?
Well, the biggest thing is to control, monitor for airway. Now, what can you do? There are medications that we can give to kind of help stop, especially like esophageal varices, where you have significant bleeding from the esophagus. The drug of choice is going to be a somatostatin analog like octreotide. Okay, octreotide, which is a somatostatin analog. Okay, so octreotide is the drug that you would probably use. You're probably not going to have that on an ambulance, but otherwise, you just got to think about what's happening. Well, because all this blood can come up and cause hemoptysis or hematemesis, that can now affect their airway. So we got to make sure that we're suctioning their airway. Like if they're fully conscious, we may even take like a Youngkower suction or a Decanto suction and just put it in their mouth and just leave it as long as they can still oxygenate well, as long as it's not interfering with their gag reflex. Depends on how much blood, but we got to monitor for airway compromise, because the thing about blood is very caustic. You do not want blood in your airway. It's going to irritate the airway. It kind of behaves like an acid. It really like burns the airway. So that would be very uncomfortable. It would be very painful or irritating rather.
Coach, would you use, I'm just trying to think of stuff that would be on a rig that I would be on. Would this be a situation to possibly suction? Yeah, but would you use TXA at all on this patient to help like prevent the bleeding?
I don't want to give you a definitive answer there. The answer is going to be that depends on your protocols. Okay. Could it be indicated? Yes. And by the way, how does TXA work?
Just preventing clots that already formed from breaking up, right?
Yeah, that's exactly. So it doesn't, okay. So what you just said is,
Platelet agonist?
So it's not actually forming clots. It's exactly what you said. It's preventing the clots that have formed from being destroyed. That's probably the simplest way I could say it. Yeah, TXA works by preventing clots from breaking down, but it specifically works by preventing fibrin from breaking down. So it prevents fibrin degradation. Okay, and so what is fibrin? So here's like, let's say when you form a clot. So let's say I make a clot, right? But then we put the body puts this fibrin, which is kind of like this mesh, over it to hold it in place. But in order for the clot to be dissolved, we need the fibrin to go bye-bye. Okay? We need the fibrin to disappear, and then the clot can be dissolved. What TXA does is it prevents, so let's put your clot back. let's put your fibrin meshwork back. It keeps the fibrin in place, preventing the fibrin from breaking down. Thus, the clot stays in place. Does that make sense?
So heparin would do the opposite. It would get rid of those fibers so the clot could break up, right?
Yes. Just at a different, so it works at a different site. So heparin specifically is going to work on antithrombin 3, which is a different clotting factor. It's all involved in clots. It just works at a different location. Heparin
Understood.
specifically works on heparin works on antithrombin 3.
Understood. And Jen had a good question. Would
What
you
was that?
feel subcutaneous emphysema on both Boerhaave's and Mallory-Weiss, or just with Boerhaave's?
I actually don't know the answer to that. Wait, so the question is, would you have sub-Q emphysema? Is that what you said?
I think that's what she wrote, but I remember remembering that with Boerhaave's you could feel subcutaneous emphysema because of the hole in the esophagus, like underneath the skin. But I don't know if it's for both or just one.
So the real answer is it could theoretically happen with both. It just depends. So what causes sub-Q emphysema? It's where you have air that went into a space like underneath the skin. So the air goes between the fascia, and high enough pressure could make even a small hole, like a small hole that's under high enough pressure, you could still end up with sub-Q emphysema. It's probably less likely with Boerhaave's, but I don't know that I would not say that it cannot happen with Mallory-Weiss or esophageal varices. I wouldn't say that it could not happen. One is just probably more likely to have it happen. But like I say, even a small hole that's under high pressure, air can still travel. Like air can go wherever it can go. Right? So that's the factors at play are going to be like the patient's own anatomy. Let's say the size of the neck, how much subcutaneous fat they have. All of that's going to play a role, but I wouldn't say, like, I can't imagine if you ever got a question like that, that's just overly nitpicky. But I can't imagine, I can't even imagine you having a question like that. Those are just like, those are like random details that are just something you saw on a PowerPoint, but it doesn't really, like, it's not going to make a difference in real life.
Got it.
Okay. Now, you want to check for, as you're doing a head-to-toe assessment, you want to check for sub-Q air, but you should be checking anytime you're doing a head-to-toe assessment, regardless of the cause, whether it's a penetrating injury due to a gunshot or a knife wound or something like that, or some other cause. You definitely want to note it. Why would you care about sub-Q air? Like, when would it matter?
When would it matter?
Because like I say, some of this stuff we're just talking about it just to be talking about it. But what you want to know is, how does it affect a patient clinically? Not just like a textbook says it can happen, but what are you going to see in your actual patient? So let's say here's your neck, and then you've got your clavicle and all that. So let's say you have this kind of pocket of air here. And you feel this underneath the skin, right? You feel this kind of sub-Q air. As you get more and more air, what else is going through here? What other structures are going through the neck?
Spine.
Okay, yeah, but what else?
Veins and arteries.
Yeah, so you got big arteries that go through here. You have big corresponding veins that go through here. You also have nerves that go through here. Hold on. I did nerves in orange. Okay. You have nerves that run through here. So, and they go a long distance. So where you get concerned is when, let's say, this pocket of sub-Q air starts pressing on some other structure, like, let's say, a carotid artery or an external jugular vein or a nerve, right? One of these cranial nerves that courses through here. That's how you care about it. Like just the fact that is there. I mean, that's just something you document, something that it's just a finding. Where it matters is this causing a problem?
Mm.
Does that make sense?
Yes, sir.
All right, Jen, did I answer your question about Mallory-Weiss and Boerhaave's? Okay, cool. Hey, Jen, are you able to talk now? Jen, are you able to talk now? What'd she say? Okay. You gotta have to be more specific about. Okay, she's a block from the station. Anybody else have any questions?
Coach, I was hoping since we were going over the spinal cord, if we could maybe go over some spinal cord injuries like central cord syndrome and anterior cord syndrome.
Okay. Ooh, you know
I
what?
feel
That
like I
would
can-
actually be
Or
just in the interest of
it's more-
time, because we're 2 hours now. Why don't
I was
we
saying maybe
do
on the
that?
next one.
Say it again.
No, I was saying maybe we could start that on the next one or something. That'd be fun too.
That would be great because I can actually draw it out. Because ooh, that would be cool. Because I can talk about. Let me just do like a quick thing now. Okay. Oh yeah. Oh, you don't even see what I'm doing. So here's your spinal cord. Yeah. Why don't we do this as a separate class?
Sounds good, Coach.
Because I'm gonna need more than about 10 minutes for this one. Because we can.
Yes, sir.
Because what we'll go over is we'll go over spinal cord injuries, and then we'll talk about like what happens in the different ones. So let's say you have, like for example, let's say you have an anterior spinal thalamic tract versus an anterolateral spinal thalamic tract. Okay. Or let's say you have a Brown-Séquard syndrome, or let's say you have a some kind of central versus lateral, or we can talk about, let's say, the dorsal column medial lemniscus here. Logan, have you even heard of these words?
Coach, could we talk about dermatomes also on
Sure.
the next one?
Sure. Yeah. I mean, it
I'll
kind of.
say there was a point where I was picking Brown-Séquard just because it was Brown-Séquard. I was like, well, eventually I'm gonna get it right.
Okay. Well, what you want to know is, so you want to know, like with Brown-Séquard syndrome, you want to know the symptoms they describe. So are they talking like pain versus temperature, and whether it's on the same side versus the opposite side? I'm gonna need a little more than about 10 minutes for that. So that would actually, I don't think I've ever talked about it with paramedic students, so that would be good. And then I'll
Cool.
like when we talk about the dorsal column medial lemniscus, we'll talk about like vibration, proprioception, things like that. We'll talk about the let's say the difference between the anterior horn, if it's just anterior, or if it's just the anterior commissure, or if it's we'll use words like decussation. So this will be great.
I've never heard.
Say
I've
it
never
again.
heard any of those words.
Huh?
I've never heard any of those words.
Okay, you think
Scaring
I'm
me,
making
Coach.
this stuff up?
Scaring me.
No, I'm surprised at how immense your knowledge is with all of this.
Coach, you look really excited to talk about this next class. Yeah, I'm excited to learn.
Is this a Tuesday thing? Is that what you're
okay? So
saying?
let me just tell you the
Hope
story.
so.
So my second semester of medical school, I met a lady by the name of Dr. Welke, Dr. Laura Welke. She was a neurophysiologist, so a PhD scientist, and she's the one who taught me neurophysiology. And so just like I draw pictures, she drew pictures like this. So she drew pictures of every part of the spinal cord for us, or the spinal column for us. And then she really like beat this in our heads. So imagine for 3 weeks. So I had neurophysiology for 3 weeks, every day for 3 weeks. And we nerded out for real. And that was probably one of my favorite, that and cardiology were probably two of my favorite subjects. So neurophysiology and cardiology. I love it.
Awesome.
Yeah. Oh, but this is something that's also not really understood, but it's not really the average paramedic instructor is not going to tell you anything about an anterior commissure, right? Or a decussation in the spinothalamic tract, or the spinal bulbar, or the spinal cortical tract, or the dorsal column medial lemniscus. That's not even going to come up in most paramedic classes. So, since you asked, Thomas, let's go.
Absolutely.
That when is your test, by the way? Oh, you haven't scheduled it.
No, I was hoping to honor about the 20th of the month.
Okay, good. So we'll have time. So yeah, that'll be our topic for Tuesday morning.
Good. I'm off that day.
Okay, cool.
In fact, coach, just kind of funny. My guys text me and they said we haven't gotten a call since I've been on this lecture. So like, can you keep going? Yeah, superstitious.
All right. So what did you guys think of today?
It was great.
Yes,
It's
sir.
great, very informative.
Let's do some hot takes today. Let's go because we actually do need to go. I don't know how these sessions keep going so long. Christian, I see you first in the box. Let's put you in. All right. So Christian, what'd you get out of today, my man?
I really liked how you color-coded and broke apart the hypoxia to respiratory distress to respiratory failure to respiratory arrest and cardiac arrest, and you color-coded it to show which one was oxygenation, ventilation, and perfusion, so we could look at the question and see.
I didn't do that today.
Well, you did it today, didn't you? I wrote it.
I didn't do that today. I didn't do that part today. I've done it many times, but it didn't come up today. But that's fine.
Oh, I could have swore it was.
Okay. Now that wasn't on another session this week, though. That did come up this week, but just not today.
All right. Well.
Hey, but that's fine.
That.
Okay. And then what else? What else you get today?
I mean, it was cool going through the brain again. I went through the brain, obviously, in paramedic school, and it's very basic on things, and you dove into each part of the brain and what each part of the brain does.
Oh, stop right there.
Especially the cranial.
Hey, what is what's the part of the brain that deals with so B flat? What part of the brain is that?
That's the hypothalamus. Shoot, it's the pituitary gland. Sorry.
Which part of the pituitary?
Anterior pituitary.
It's going to be anterior pituitary. So what are the things that make up B flat?
Oh, basophil.
So it has basophilic staining, which means it stains blue. Okay.
And then F is FSH.
Follicle stimulating hormone.
Follicle stimulating hormone.
Okay. What does it produce?
Luteinizing hormone for L.
Hold on.
Right.
Follicle or follicular stimulating hormone produces what hormone ultimately? Estrogen.
Estrogen.
Okay. Luteinizing hormone, LH, produces what? Or it controls the production of what?
Luteinizing.
That's going to be progesterone and growth of the placenta. Okay.
Okay.
What else? Keep going.
So LA is this one. I don't remember.
Help him out, somebody.
ACTH.
Okay, which stands for?
I should have written down what they stood for. I'm going to go back and do that on the replay.
Okay, here, let's go over it.
But I know it's adrenal.
Okay, so let's do it quickly. We really do need to go. I think I put that in like a turquoise blue. Let's do that again. So we're talking about the anterior pituitary. So F is FSH. That's follicle or follicular stimulating hormone. So we'll just put hormone, H for hormone. That's FSH. Then we have LH. That's luteinizing hormone. Oh, follicular stimulating hormone produces or regulates estrogen. LH regulates progesterone. Okay. A is ACTH. That's adrenocorticotropic hormone. Adrenocorticotropic hormone. And then T is TRH. That's thyroid releasing hormone. Okay. And then what about the posterior pituitary? So this is your anterior.
Vasopressin and oxytocin.
Okay, so this is your anterior pituitary, also known as the what?
Oh, is that fancy word?
Adenohypophysis. And then your posterior pituitary, also known as the neurohypophysis. Okay. And it does, give me the two big ones here.
Vasopressin and
Vasopressin.
oxytocin.
And oxytocin. What does vasopressin do?
It constricts the.
It regulates, it
muscles.
does vasoconstriction. Okay. All right. And what does oxytocin do? Give me two things.
Milk,
Milk.
Say it again.
milk production and uterine contraction.
Don't say milk production. That's different.
Okay.
That's prolactin
Gotcha.
that does that.
Okay.
Because there's a difference. One of them is you make the milk. The other is you pump out the milk. It does the pump out the milk
Okay.
part, which is milk letdown,
Oh,
or milk ejection. Okay, so in breastfeeding, the actual milk coming out part, that's under control of oxytocin, but making the milk is under the control of prolactin.
Where does prolactin come from?
It's also, I mean, it's also in the pituitary. And then what else does oxytocin do?
Controls uterine
Yeah,
contractions.
uterine contraction. Okay. All right. My pen is dying. All right. That was a lot. We covered. Let's just recap what we covered today. Oh, we started off today with cranial nerves. Then we went to all kind of stuff about the brain. We talked about tetanus and how it cleaves the snare protein, how it's the Clostridium tetani bacteria. We talked about serotonin syndrome and SSRIs and how SSRIs are selective serotonin reuptake inhibitors that prevent serotonin from going back up into the presynaptic vesicle. And we talked about serotonin syndrome and thyroid storm and how you're going to treat thyroid storm. Then we went deep into the brain. Wow, this is different. Then vertebrae, then pituitary, anterior and posterior pituitary, hypothalamus and thalamus. Talked about how to, like if they have a thalamic seizure and how you treat that one different in like an absence seizure. You treat that. The drug of choice is going to be ethosuximide, which behaves like a calcium channel blocker. Then we went into Mallory-Weiss and Boerhaave and GI bleeds. And then, so where we're going to pick up the story on Tuesday is we'll go into spinal cord injuries. This will be awesome. So, Logan, how did you feel about today?
I mean, I feel like I've got a lot more knowledge than when I started, specifically on the brain. I mean, I was just, doing stuff on the brain in my remedial training the other day, and I'm like, I don't know nearly enough on this. So I'm glad we got to talk about it.
Okay. But don't just go through it one time. Go back over the same video, but also take the time. The magic is saying it out loud and drawing pictures of it.
Yep.
So I want you to draw pictures of it yourself.
Yep.
And kind of recreate what we did today. So
I got a bunch of really ugly pictures here of it, but
that's
they're
okay.
here.
That's all right. And then Cody, you came in late. This is a great video replay to go back and do. I read your message to him about the seed tricks and stuff like that. The five-star medic method and the
Yep.
5 steps. Yeah. So I read that today. What did you get out of today?
Well, I came in kind of last minute, but I got in. To back off of Logan, I'm really bad when it comes to the brain and all that. So that was good to get a little recap on all that.
Okay.
And so I can go back and rewatch it multiple times, start drawing more pictures.
Okay. Cool. And Thomas, how was today, man?
Oh, it was very good, coach. And first of all, thank you for your time this evening. But it was a great refresher on cranial nerves, and then going through serotonin syndrome.
Okay.
And Mallory-Weiss was a really good refresher on that.
Nice. And you're saying like your paramedic school wasn't like this at all?
Oh, no, sir.
What's the difference for you? And you guys hear me ask this question a lot because I really want to know, like, how are these programs?
I mean, they have a good foundational level, but they don't get super into detail on things that help you kind of understand the pathophysiology and like the big picture and tying everything together.
Mm-hmm.
So I think understanding the why behind things just kind of makes everything else a little bit easier to understand.
Absolutely. You have less to memorize when you really understand it. Okay. And the more you keep drawing these pictures, the better you're going to be. I promise you.
Yes, sir.
Okay. Christian, what was today like? I think I may have talked to you already.
You did.
Okay.
But it was wonderful.
You asked or you made a statement. You said, "I'm surprised you know this stuff." Why are you surprised?
I'm not surprised. I said I was, what's the word I used? I was impressed, I guess is the word I would use, but I was just in awe that your brain knows all of this stuff. That's what I was trying to say. It astonished. That's the word I used. Astonished me.
Oh, okay.
That you could remember all of those words and all of those things.
I'm curious. What makes you think? I mean, I actually do know what I'm saying. What makes you know that I know what I'm saying?
Trust. Okay. I mean, you could, for all I know, you could be making up words, but I know that you're not. I mean, you've said a million times all of the different certifications that you have, the 20 plus certifications, plus all the experience you've done, and you're getting your doctorate and going through all of that. So I know that you have an immense knowledge. It's just, I don't know. It's impressive. It's impressive that you could remember all of those words and all of those names. I went through a year of paramedic school and, forgot half of the medical terminology or names of things. And it's only been a year, and I'm sure it's been a long time since you've learned a lot of this stuff, but it's still fresh in your brain. And then that got my brain to thinking, okay, well, how come it stays fresh in his brain and not in mine? And you revert back to your pictures and how when you think of things, it comes up in your brain as a picture, and that's how you remember those things. And I'm sure you have different acronyms or things that help you remember, and I'm excited to see what those are so I can start remembering things.
And I will say the secret weapon that I have is pictures. And now you know my secret.
Hey, Coach. Coach, could I add in to what Christian was kind of saying, the way you can explain things? I think from my perspective, you have an ability to articulate subject matter far beyond what we're used to getting in a regular paramedic program, and that's like the key difference.
Well, I appreciate that. Can you be a little more specific?
It's your ability to really break down the pathophysiology and the why behind things. Like we get a basic kind of foundational knowledge in paramedic school, but the actual way you can articulate things and draw them out in detail and explain this to them and the science behind them, it just makes much more of a difference. At least for me, it does.
And thank you.
And in my paramedic,
I will say,
paramedic school.
I will say that I appreciate you guys being patient with me, because some things, like when I'm getting asked a question like right now in real time, I have to process it real quick and then figure out, okay, how do I draw that? So, because I'm not a machine, I still have to sometimes like filter it through my head real quick and pull up the file so that I know, like, okay, how do I say it and how do I draw it in a way that makes sense? Because I will say that you have to understand things at a much deeper level, especially to be able to draw it, right? And to say it in some kind of way that makes sense, hopefully. And some things I talk about all the time. And so I can just blurt them out. Other things I have to like sit and think for a second. and then very quickly the picture comes up and I'm like, okay, I got it. So thank you guys for being patient with me, because I'm having to do this stuff in real time in front of you. Because I don't have any notes.
Absolutely.
So, like today, I had no idea we were going to talk about cranial nerves, but there we were. But thank you guys for being patient with me. I hope that I'm never trying to impress you with what I know. Believe it or not, that's actually not the case. What I want to impress upon you, though, is that it's not that I'm just so smart. It's just that I have organized information. And the way I got to this point is I have drawn lots and lots and lots of pictures, thousands, like 10, some things I've literally done like 10,000 times. If you will start doing that, you're going to be, your knowledge is going to go through the roof. You're going to be able to explain things that other people don't even know about. They don't even know to consider it. As I've mentioned so many times, that's going to open the doors for you to be able to go on to PA school, nursing school, nurse practitioner, medical school. Or if you say, hey, you know what? I want to do something completely different. I want to learn AI. I want to learn graphic design or whatever else. Just like one of the things that we've started doing is unlocking your brain to where you can now learn anything. Okay. So medicine is obviously a very difficult subject to learn just because it's so heavy on terminology and stuff. But once you learn it, you can learn anything. You could say, hey, you know what? I want to learn law, and I'm going to go ahead and go to law school. and you can, because you're going to still use the exact same brain, right? You're just going to learn a different subject. So one thing that I hope I've done for you is show you the power behind learning more.
Definitely.
Yeah. And the other thing I hope I do, which I don't know that I do this well, but I hope I do this well, and that's convey to you that I like this stuff. And I don't know if that comes across because, I'm just looking one way into the camera, so I don't necessarily always see what you see until I watch the replay.
Definitely. I could tell.
Okay. And do you mind elaborating on that?
I had teachers in my paramedic class that I could tell did not want to be there, did not want to take the time to like actually dive deep into things and, and teach us the how and the why of things. And, maybe got like whoever wrote the paramedic book, I forgot the company's name, but I remember we had a teacher. He actually ended up leaving halfway through the year because we were like, this guy's not teaching us anything. But he used the PowerPoints that were pre-made from the company that had the paramedic book and was just going through these bullet point presentations and wasn't deep diving on why this is happening and how this is happening. And I noticed that here. So
well, it takes a lot of time for one thing. It does take a lot of time to like explain all this stuff. But what makes it easier is when you actually understand it. And what I've found with just so many paramedic instructors that I've met over the years is they fundamentally don't understand. Like, because think about it. If you had a teacher who only taught you out of the book and then you learn, you kind of still only know what you were taught by the last person out of the book, right? Unless you went on a deep dive yourself or you found somebody else who knew more, that's your base of knowledge. And you can't share what you don't have. So you can't give to others what you first yourself don't have. So it's hard being in this seat because I actually have to know 10 times more than what I give you, like at any moment, because I never know where the questions are going to go, right? So I promise you, I don't give you all of what I know. I wish I could. It's just we don't have that kind of time. But I have to know so much more. But what you guys don't see is the hours that I spend studying behind the scenes. You only see the part that's on camera, but I promise you, there's a day-to-day track record of me diving deep into this stuff, like on a regular basis. So,
even to this day,
say that again.
even to this day.
Oh, absolutely, yeah. Oh, yeah, because there's some things that I just haven't, I hadn't really had to deal with in a long time, and so the only way I can keep it fresh on my mind is like. Now, the other reason I like pictures, though, is I can look at a picture quickly and I can like instantly like re-download the information. It would take me a lot longer if I had to go read. But
Interesting.
especially because I'm writing on my iPad, so there's always a record of everything I'm doing. So I can just thumb back through really quickly to something from 8 years ago, and I can just pull it up really quickly. And because it's a picture, I'm like, okay, got it. But if I'm a much slower reader. I'm a great reader. I'm just a slow reader. So reading takes me a lot of time, but pictures I can pick up immediately. But everybody's the same way. You're the exact same way. You may be a fast reader, but you can still pick up a picture and you can get a lot of information out of a picture very quickly. All right, guys, we're going to go because we're over time. But I hope this session was beneficial. The replay will go up probably tomorrow. All right.
Thank you.
All right, everybody have a good night.
Yep.
You
Thank
too,
you,
Coach.
Coach.
Okay, all right.